postgraduate case presentation. So today we are very privileged to have Hari sir as our examiner. As I mentioned earlier, I think it's the third or fourth time Hari sir has acknowledged our invitation and being part of this Ampok case presentation. So today we are discussing a case of splenomegaly. And then we will not discuss only CML. I think it should be an entire. We can go into that. All the differentials needs to be discussed because splenomegaly is a major case which which can take us to any level in a medical oncology examination. I request Udiptia to take over the proceedings. So over to you, Dr. Udiptia.
Thank you, sir. Thank you all. And I think, Pavitra, we can go ahead and start the presentation.
Esteemed faculty, so today I would like to present a case. My patient is a 19-year-old female from Ernakulam. She is a laborer by occupation, and she presented with the complaints of pain abdomen from the past 3 months and an early satiety from the past 1 month, sir. History of presenting illness. Patient developed pain abdomen 3 months ago in her upper left side of the abdomen, which was insidious in onset, dull aching, non-radiating, continuous in nature, and it was not associated with any exacerbating or relieving factors, sir. And it was also not associated with food intake, nausea, or vomiting. Patient also developed early satiety 1 month ago, which was gradually progressive in nature. Apart from that, there was no other history of altered bowel habits, vomiting after meals, or blood in the vomitus, or other dark colored stools. Sir. There was no history of fever, weight loss, night sweats, no history of swelling elsewhere in the body, no history of repeated infections, no history of bone pain, bleeding manifestations, no history of blurring of vision or headaches. Sir. Coming to the past history, she did not have any similar complaints in the past, and she is not a known case of diabetes, hypertension, dyslipidemia, or coronary artery disease. There is no other significant past history. And personal history, as earlier mentioned, patient is having a decrease in the appetite. Bowel bladder functions are normal, diet is mixed, and the patient does not have any addictions. Menstrual history, patient attained menarche at 13 years, and she is an unmarried female. Drug history, there is a patient is not on any other regular medications. Summarizing the history, my patient is a 19-year-old female with no known comorbidities, presenting with a history of pain abdomen since the past 3 months and early satiety since the past 1 month. Sir. So shall I proceed with the history, sir?
Yeah, please go ahead.
Yes. Sir, on general physical examination, patient was conscious and cooperative. She was examined in a well-lit room, conscious, cooperative, well-oriented to time, place, and person, sir. She had an ECOG performance score of 1. Pallor was present. However, there was no palpable lymphadenopathy, including supraclavicular nodes. There was no pedal edema, sir. Her vitals were all within normal limits. And on examination of the abdomen, inspection-wise, her abdomen was flat, umbilicus was central and inverted. All the quadrants move equally with respiration. There was no visible lump or fullness in any quadrant, no engorged veins, pulsations, peristalsis, and no visible cough impulse was present, sir. On palpation, there was no tenderness and no local rise in the temperature. Spleen was palpable 6 centimeters below the left costal margin, extending downwards and medially. It was firm in consistency, smooth surface, moves with respiration. All the borders except for the superior border were palpable, and a splenic notch was felt, and spleen was approaching the midline. There was no hepatomegaly, no other palpable mass, and no pulsations felt, sir. On percussion and auscultation, the abdominal examination had a dull node found on the left hypochondrium in the lumbar area. There was no shifting dullness and a normal liver span of 12 centimeters. Other systems were all within normal limits, sir.
Yeah.
So summarizing.
Given the current symptomatology and your clinical findings, how would you best correlate the findings, keeping in mind certain specifics as far as this patient is concerned?
Sir, first of all, a patient is having chronic symptoms of around 3 months. So I would like to keep a differential of malignant causes above the benign causes. And in malignant causes, since the patient is having
Why would you
spleno.
say? Why would you specifically say that it is malignant cause? Is the first of all, the patient is she a resident of Kerala? Is she a resident of Kerala?
So yes, sir, she's from Ernakulam. Sir.
Yeah, she's from Ernakulam, all right, but she's a resident of Kerala.
Yes,
Does we are talking about a young patient who
yes,
has presented with relatively, I would
yes,
not say really chronic. I would put it more like something
subacute.
less than subacute. Yeah. So being symptomatic and with the symptoms. So the major symptoms that she has is, could you elaborate that once again?
Yes. Sir, she's complaining of left upper abdomen pain and early satiety. Sir, upper abdomen pain is present from the past 3 months, and early
Mhm.
satiety from the past 1 month. Sir.
So what about, is there any history of weight loss?
So no, sir, there is no history of weight loss, sir. So
So
yes, sir.
when
Sir,
that is yeah.
yes.
So when that is the case, why would you be you made a statement that my first this thing is some malignant process. Would that be really appropriate over here for us to say that it is a malignant process rather than keeping some other aspects in mind? Yeah. Because yeah.
Sir, actually, I was also thinking in terms of given the prevalence of tuberculosis in our country, I even thought
I
of
don't think you should talk about tuberculosis because I don't believe that tuberculosis is something you've already committed. That's why we said that you have gone ahead and described the clinical findings. Yeah, but it's unusual for you to have tuberculosis with a spleen of that kind. Yeah, there may be several other causes. So that's why I specifically asked, is the patient from Kerala or not? Yeah, has that got anything to do with that for a 19-year-old to develop a moderate to large splenomegaly? Yeah,
uh, Kala azar can be one of the
so that
infections.
could be, but more than that, what is more common? Yeah, than that.
Sir, I'm not sure, sir. I would be in an in a 19-year-old female. I would even think in terms of autoimmune disorders.
Yes,
Um,
yes, that's one of the things. Yeah, autoimmune disorders can manifest with this, but she lacks all the constitutional symptoms and
or
it is sort of subacute, isn't it? Yeah.
yes,
So what autoimmune disorders would you consider as possibilities in a 19-year-old
sir.
having a
SLE could,
moderate splenomegaly? Yeah.
sir. SLE could be one of the causes. Rheumatoid arthritis could be
Then
one of the
she would
causes.
have many other symptoms
Yes,
if the
yes,
patient has presented with a splenomegaly which is so significant, and if you attribute it to SLE, I'm sure that she would have many other symptoms attribute, which she doesn't, isn't it? Yeah.
yes.
Yeah. So even when you give your differential diagnosis, you should be more judicious about what you want to say and try to narrow down in several ways. You can have surprises, but you need to narrow down, isn't it? So
Yes.
yeah, yeah, okay. So what are the other autoimmune disorders that can actually manifest with um, splenomegaly, which is probably unlike this case because she is a 19-year-old, but still, if it was, say, a, a middle-aged lady, what are the other things that can present with splenomegaly? Yeah. Hmm.
My first differential in terms of autoimmune, my first differential would be probably SLE is what I would be
Actually,
thinking.
okay, you've already mentioned, and rheumatoid arthritis can present with splenomegaly, isn't it?
Yes,
Yeah.
sir.
One of the causes of
Yes.
rheumatoid arthritis or rheumatoid-like disease. Yeah. So those things. Okay, let's move away from this thing. You have already. What makes you say that this is a malignant process? You committed say that it's probably a malignant process. Yeah.
Sir, I would be probably like ruling out the other etiologies. I'm ruling out infections because there is no history of fever or any other associated symptoms of those particular infections. And as I said, the autoimmune causes would probably present with other B symptoms. And apart from that, they would even present with vague aches and pains in the body, like joint pain, uh,
So does the patient have these symptoms
myalgia, which would be more
associated?
common in splenomegaly.
So if
One of
if there was a more compelling kind of symptom that we would attribute when a patient has splenomegaly with a 19-year-old, what would it be? It would be mainly the B symptoms, isn't it? Yeah, yeah.
yes.
If it is a malignant process, and in a 19-year-old, you say it is subacute. It looks like a subacute symptom. What are the other differential diagnoses, since you say that it is a malignant process, in terms of your DDs that might be over here?
Shall I enumerate the malignant causes that I'm
So what
thinking?
you don't have, you tell me. Yeah, you
Yes.
tell us what you
Uh,
think. We are only
yes.
trying to explore your thought process over here,
Yes.
nothing else. Yeah.
So when it comes to malignant causes, I would be thinking in terms of a chronic myeloproliferative or a lymphoproliferative disorder. Is those are two of my differentials. Apart from
In a
that, I would be thinking,
19-year-old, which is more common? Yeah.
sir, actually, lymphoproliferative
Yes, it's a
disorder is
lymphoproliferative
much more
disorder.
common.
And so, what would you associate it with other lymphoproliferative now that you have already had a clinical evaluation of the patient, which will negate that possibility over here?
So I have the question, sir.
No, which will negate the possibility of being a lymphoproliferative
Yes.
disorder. The
So
chances of being a lympho. We are not saying that it cannot be,
yes, yes,
but just to
yes,
just to say that what will negate the possibility of this being, because
sir.
most of the
Patient
you would expect that most of the lymphoproliferative disorders in
will
this
present
age
with
group would be
yes,
very aggressive. Do you
yes,
agree or not? Yeah.
yes, yes, sir.
Because
So patient,
everything is about looking at commoner manifestations than looking at rare manifestations. Yeah.
yes,
Yeah.
yes.
Okay. So
Sir,
would that be the case over here for us to think? Yeah.
sir, actually, lymphoproliferative disorder in this age, we would expect more of B symptoms and lymphadenopathy.
Yes. So you didn't have those things, and patient
Yes,
doesn't say so.
yes,
Yeah. Okay.
yes,
Yeah.
yes.
So yeah. So go ahead. Go ahead. Yeah. Then.
Sir, lymphoproliferative disorder, as I mentioned, was one of my differential, but I'm ruling it out probably, thinking in terms that there is no
No,
B
you should say
symptom or
not completely
lymphadenopathy.
excluding it. Not
Yes,
completely
not
excluding it.
completely.
Okay.
Sure,
Yeah.
sir.
Okay.
Sure,
Yeah.
sir.
Okay. Then.
Sir, and since the patient is complaining of abdominal left upper quadrant pain along with some amount of early satiety, it would be a far shot, but still there is still a possibility of CA stomach or something involving around the splenic flexure of the colon. That
So
also could be.
I mean, you have committed to the fact that this is a spleen, but what if it was not a spleen in this age group, a 19-year-old, what would be a commoner kind of a tumor sitting there in the abdomen?
Stomach or splenic
You don't
flexure of the
expect,
colon.
you don't expect, do you expect stomach, though we do see on rare occasions, but do you expect a malignancy involving the stomach in this age group?
No, it's a very rare
So
possibility of.
I, so I, this, so as I said, when we talk about think about the commoner possibilities. I mean, you can always have surprises, but
Yes.
think about the commoner thing, and you should be able to at your level when you're trying to rationalize what your uh, possible diagnosis based on the should have some basis in terms of that. So what could be the other things? Could it be any of the germ cell tumors, for example, the patient can present in a 19-year-old?
Yes. Possibility of
Yeah, the
germs.
patient can present with germ cell tumors, isn't it? What is the
Yes.
common germ cell tumor that you see in a 19-year-old lady? Yeah. They can present with lymphadenopathy, which can be in the left hypochondrium, isn't it? But more so with testicular tumors. But in this here is a lady What other tumor can you can? Okay, you have committed to the fact that it is a spleen, so clinically, but still, I'm just from the perspective of discussion. Yeah, yeah.
Not able to recollect at this point of time. I'm unable to recollect anything at this point of
So,
time.
so I can see some pop-up come up where somebody has said dysgerminoma. Yes, that is something that needs to be considered over here. Yeah. Okay. So that's fine. So go ahead. So here you are having a patient. You may say that is manifesting with relatively recent symptoms, mainly only early satiety, abdominal discomfort, no B symptoms otherwise, and clinically has a splenomegaly only. So now how
Yes,
do we proceed? Yeah. And you specifically said some of the negative features over here, some
yes,
negative history, a whole load of negative history, but your negative history also should reflect your thought process. You don't have to
yes,
say all the negative history that is there all over. Your negative history should reflect the thought process, isn't it? Yeah. Okay.
yes.
So you did mention something about headaches and visual disturbances, etc. How does that matter over here?
I said if the since the patient would be probably presenting with splenomegaly at this point in the history, I would even keep a differential of CML in my. I would even think in terms of CML. So if the patient is come to me with CML and leukocytosis, hyperleukocytosis presenting in blastic phase or accelerated phase, they may have leukostasis. Features of leukostasis are possible, and
That's
that
not
is when.
necessary. That's not necessary in just blast crisis. You can even have it with hyperleukocytosis. And generally, patients complain of headaches and um usually the kind of leukostasis that the symptomatology is more for acute leukemias than for CMLs. Yeah. Yeah.
Yes.
So but the patient can manifest with symptoms related to um, hyperleukia in the form of headaches. That's a possibility. But anyway, that's a very sort of a weak kind of a negative history that you've seen. Okay, I will. You go ahead. I'm sorry, I'm not law hogging. I mean, my other colleagues should also be asking questions. Yeah,
No,
please.
sir, I am also sitting and learning. I think
No, no, no,
uh,
no, please go ahead. Yeah, so yeah, go ahead. Go ahead with your how do you so you have confirmed that this is a 19-year-old with a splenomegaly and we're coming with symptoms of early satiety and the patient has gone ahead and you want to investigate this patient
Yes.
from these perspectives. So how do we
Yes.
go about it? Yeah, yeah.
Uh, Sir, after my differential, sir, can I show the investigation? Sir, I would first proceed with the.
So you don't show
Com-
me the investigation. You tell me
yes,
what you want to
yes.
do as far as this is.
Sir, I would like to
So
proceed
the
with the.
patient has come to you, the patient has come
Yes,
to you, and then I'm sure you have access to all those investigations, but that's not how we need.
yes.
You tell us how you want to,
Sorry.
as a new patient, has come to
Sure, sir.
your outpatient today, and how you want to approach this patient. Yeah. Yeah.
Yes. Sir, I would like to order for a complete blood count along with the differential count for the patient, sir. Sir, and along with that, I would even like to order a basic biochemistry tests, including a liver function test, a renal function test, and serum
So those are all
electrolytes.
routine tests, but what are you specifically looking for in these actually? Yeah.
Sir, I would like to order a peripheral smear, in which I would
So
in
that's
the
basically based on the premise that most of the splenomegaly have in some way related to the hematopoietic system, isn't it? So that's the reason.
yes,
Okay, yeah. So
yes,
okay, you have ordered a CBC and a peripheral smear, and
yes.
what are you looking for in the liver function test? As far as what is your thought? What are you trying to look for in the liver function test?
Sir, I would like to see the OTPT levels basically because
Why
if I'm
specifically OTPT levels? Why? What are you concerned about over here to look at for the OTPT levels over here? That you're specifically asking for the OTPT levels.
sir, basic liver function we will need before
So that
starting.
is there, that we are doing. But when you're asking for this thing, keeping in mind certain specific TDs, what are you specifically looking for in the liver functions and the renal functions?
Sir, in the renal function, I would be looking for a creatinine and uric acid levels,
Hmm.
and So basically, I would like to rule out if any TLS, anything symptoms of definitions of TLS that are associated. So that is what I would rule out on the renal function tests.
Okay. So you're looking basically for the any suggestion of a hematological condition affecting the renal system, yeah, or
Renals.
in the terms of biochemical profile. Okay. So go ahead. So tell us the reports that you saw in this patient over here.
Yes.
Yeah.
Sir,
Because
in
many a
the
time in a splenomegaly, just a peripheral smear itself clinches a diagnosis. So
yes.
let us know what you see. Yeah. Over here. Yeah.
Sir, I'm finding that there is low
So
hemoglobin 5.7. There is an anemia along with
So you just have to
hyperleukocytosis.
say that you just have to talk about what you see over here. So the
Yes.
patient has anemia, the patient has hyperleukocytosis,
Hyperleukocytosis. And
and
there
the
is
patient has
left shift of.
and she has a normal platelet count.
Yes.
Yeah. And what do you mean by a left shift?
So there are more of immature forms of WBCs that I'm seeing.
And what
More
is
of
that?
band forms, such as there are myeloblasts, there are promyelocytes and myelocytes that are being seen that are generally not.
Okay. So what is that due to?
Uh, so that
So
is because of
when you see such a picture
yes,
with
sir.
hyperleukocytosis, what comes to your mind? Why should this happen in the peripheral blood? Yeah.
So that is because of the poor differentiation that is occurring.
Is it because of differentiation or is it because
Um,
of something else? Where do you get differentiation problems in the
so
peripheral
that is
blood?
actually in APML that we get
Yeah,
the
so
differentiation.
that's not the reason
Yeah.
why you get this kind of what is this generally called over here? What is so profound over here, which is not normally seen in the in a peripheral blood in a normal CBC? Yeah, so
Uh, all the
it's
immature
got a,
forms are coming into the
yeah, immature
circulation.
forms. So
Leukemoid
basically
reaction.
basically
Yes.
it's reflective of a spillage of the bone marrow into the circulation, isn't it? Yeah.
Yes.
Yeah. So what is
Yes.
it what is it popularly called? It's called generally you don't see so many promyelocytes and myelocytes. It's almost
ഇത്രയും ഞാനൊരു എക്സാം നടത്തിക്കൊണ്ടിരിക്കുകയാണ്
Usually like
it's
leukemoid.
about it's
I'm not
about
sure.
32
വിളിക്കാം
it's
8:30
almost
ആയിട്ട് വിളിക്കാം
32% of your 32% of the total population of cells. So what is it called? It's called a myelocyte bulge, isn't it? Usually you say
Yes.
it's called a myelocyte bulge. And when you see a myelocyte bulge, it directly brings you down to some aspects. And what other things strike you as very significant over here?
Sir, in this patient there is eosinophilia and there is
More than the
basophilia.
eosinophil, what is the thing that really should strike you? Okay, this is having this, so this has
Basophilia.
to be something, yeah? The basophilia, isn't it?
Yes.
Yeah. Yeah. The basophilia is the one that strikes. Eosinophils can be otherwise also present in other conditions also. Yeah, but you don't see basophils like that in it. So you have a myelocyte bulge and you have and a basophilia. And are you concerned about the blasts over here?
Yes. So
Why are you concerned
blasts
about
are
the blasts?
focused. So
Are you,
blasts are
my question was, are you concerned about the blasts over here?
uh, not really, not
Why?
at this stage.
Why?
Uh, I would only be concerned if they are crossing more than 20%, more than 30%. And
You must say whether it's
this could
20
be
or
the
30. Yeah. 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 So because as per the newer classification of now, if you look at what is the newer classification? Now we're thinking that we're talking about CML over here. What is the newer classification that will uh, uh, put the categorized CML into?
so actually now the accelerated phase is taken off.
Yes.
and
So you
we
don't
only
have
classify.
accelerated phase. So if you have to categorize it as blast crisis, what is the percentage of blasts that is a cutoff that we usually look at?
So more than 30% is what we would still look at.
Okay. And if there is that kind of a cutoff is not there, and you, how would a besides the blasts as such in a blastic in a myeloid in blast crisis vis-a-vis a CML in chronic phase, what will be some of the striking features and what are the differences in the peripheral smear? Of course, we will say that the blast percentage will be high, but what happens to the myelocytes and the promyelocytes and the eosinophils over here?
Sir, in the when we come to the accelerated phase, uh,
You said we are not talking about accelerated
we-
phase anymore because it's been given up. Yeah. Yeah.
there are
Yeah.
actually basophils of more than 20% is what we would
So
be earlier
there,
quoting.
there will be persistence of basophilia, but what you see in a blastic phase would be more of blasts, less of promyelocytes, or hardly any myelocyte, but persistence of the blasts. You don't see much of eosinophils, and you see predominantly neutrophils and blasts. That's the most common population over here. Yeah, that is one of the subtle changes that you see, which you have to look for in the peripheral smear, even when a patient who has CML, who's probably transforming into a blast crisis or a little bit more of an intensive. So over here, looking at this picture with the splenomegaly, you would say that your preliminary diagnosis, you're more or less certain that this is going to be uh, a chronic myeloid leukemia.
Yes,
So then
more in terms of.
how do we go ahead and what will be your next step?
So we will. I would like to ask for a peripheral smear.
So you've
Apart
already, okay,
apart
you
from
asked for
that,
a, okay, I was imagining that this was a peripheral smear. Anyway, so this is a Coulter report. Okay, so what are you
uh,
looking on? Yeah, okay. What are you? The Coulter is quite a sensitive indicator in terms of picking up these differential counts as being consistent with this thing. Okay, but yeah. So what else would you like to do? What happens to the um, uh,
I would like to ask for a bone marrow study also. So bone marrow aspirate imprint and biopsy,
why do you
along with the.
why do you want to do a bone marrow over here?
Sir, I would like to look at the fibrosis that would be present. Secondly, I would like to do a conventional karyotyping also, which would be obtained from the bone marrow study to look for any additional chromosomal abnormalities.
Okay, that is sweet,
Yes,
but I guess with the current techniques, etc., you're right in terms of saying that okay, you would like to look at myelofibrosis, but that is for the discerning person. But nowadays, you many are not doing the bone marrow, but as a teaching process, I would say that for academic purposes, it is best to do a bone marrow biopsy at baseline to understand the myelofib because at least then you can anticipate sometimes problems of cytopenias, etc., when you are treating patients with CML. So anyway, that's besides the point. But what other tests you'd like to look at? Would you want to do the LDH levels, and what happens to the LDH in chronic myeloid leukemia?
CML LDH is elevated, sir.
So that would
Uh,
indicate is it significant?
so it's a negative prognostic factor.
No, it has no relevance actually in this thing. It is just a indication of the proliferative process that is happening in the bone marrow, which will cause the LDH to be raised. Yeah. So it generally doesn't have, but many people do it, but it has no impact on the way that we need to treat CML. Yeah. Okay. Yeah. So um, yeah. Okay. So what next after this? Would you like to categorize this patient into certain risk groups over here? And would you like to discuss what are the risk groups that you would like to put this patient into, and what will be the way that you want to, in the current
Yes.
age, what is the risk stratification that you would like to do?
Sir, there are multiple risk stratification groups, but now in the TKI era, we have got the ELTS risk score stratification, sir, and components of which include age, platelets, percentage of blasts, and splenic size. So these are the four variables that we would include, and we would further based on these, we would
So how is it
categorize the
similar
patient.
to how is the ELTS score? Is it similar to, and how is it different from the Utah score? And how is it different or similar to the SoCal score?
Sir, when we compare it to the SoCal score, the components are very similar, but
Components are
SoCal's,
absolutely the same. Yeah.
yes. So,
But
but SoCal
components are
score
absolutely the same
overestimates.
as far as SoCal score is concerned, isn't it? Yeah.
Yes,
Yeah.
yes,
But what is the difference for the ELTS and how does it translate into, yeah,
yes.
how does it translate?
Uh,
How is it become relevant in the TKI era?
Yes, sir. Sir, in the SoCal score, it overestimates age. SoCal score gives more importance to the age. But now we know that TKI is
So
useful.
it,
We can use TKIs even in patients who are older aged. So
so basically, how is it
importance to
changed?
age is.
How does it change the SoCal to suit the ELTS score? How does the ELTS score, what modification was done? It is basically the weightage that has been given to each value, isn't
Yes.
it? That has really translated into, which allow for, what does it best prognosticate, the ELTS score?
Sir, it gives us about the overall survival, median overall survival for a long time. And secondly, it gives us about the complete cytogenetic response at 18 months.
But that is the Utah score, actually. Yeah.
Utah's LTS.
But generally the Utah score is incorporated into the ELTS score. What does
ELTS.
ELTS stand for?
Utah's long-term survivals.
Long-term survival. Correct. Good. So the thing is, when you're talking about the ELTS score, um, it also predicts for it has got a more stringent kind of it's got a more stringent kind of a categorization because you can be quite sure about what other aspect of prediction does the ELTS provide besides overall survival, which is more important these days in the management of CML rather.
Not sure, but response to TKI, I remember vaguely
Yes, the
reading
TKI,
response
but
to TKI.
also the chances of the patient going in for a TFR is also something that can be predicted based on because you categorize it into low, intermediate, and high risk. And if you are truly having on the ELTS score uh, a low risk score, your chances of progression is less than 1%, which goes up to around 12% and which goes up to around 22% as you go. But so when you know that that kind of a high risk is there, you can also sometimes discuss the possibilities of TFR at a long on a long-term basis on to some measure. But you're right in saying that it is mainly for long-term outcomes, yeah, as the abbreviation will suggest. Okay, so let's move on. Okay, move on from this thing. So here, so what score does this patient fall into?
Fell into intermediate risk score, sir.
Why? Based on the ELTS? Yeah.
Based on SoCal and ELTS, both patient was falling into intermediate risk scores.
Okay. Okay. So how would you like to approach this patient?
Uh, so I would also do a FISH and qPCR for
Right. Right.
zeroing down
Of course.
diagnosis.
So that's why I ask, how do you approach
Yes.
this patient at this point? Why is it relevant? And why do you want to do a fish?
Sir, I would like to do a FISH to rule out cryptic translocations that
But
are there.
if the qPCR is already showing a standard transcript type, why would you want to do a fish over and above? Okay, if you are strongly thinking that it is a CML and your BCR-ABL comes back as negative, then there is meaning in doing a fish. Would you agree with that? Or is it mandatory that you do a fish?
Sir, and in our institute, we are generally following this practice of
No, we're not
FISH.
talking about what is being I'm asking you from a perspective of the question, is it important for you to do a fish when you're now currently doing it? Unless you're thinking about It is important to do a cytogenetics, which you correctly said. That is important for us to understand whether there is any additional
Additional chromosomal
additional
abnormality.
chromosomal abnormalities that are present. But if your BCR-ABL is positive, what is more relevant over there when your BCR-ABL is positive to identify?
Sir, I would like to go for a qualitative PCR to know the type
And
of transcript.
yeah, so how does the type of transcript, has it got any influence in has it got any importance in the present day?
So yes,
Type
sir.
of transcript.
Depending upon the type of transcript, sir. So
Yeah.
there are three different types of transcripts that we know of, sir. Major, minor, and the micro. The major transcript being P210, sir. It is 210 kilodaltons, and the translocation occurs at exon 13 and A2, or exon 14 and A2. This is seen in most of the cases of CML, sir. The minor transcript, which is the P190, which occurs at E1A2 translocation. This usually is seen in pH positive ALL cases, sir, and in CML, few cases of CML. So this carries it is a aggressive disease, so carries a poor prognosis, sir. Sir, and the P230 variant, which is a micro variant, that is seen in chronic neutrophilic leukemia, and may be seen in indolent disease,
But
indolent
we are
groups.
talking about CML right now. That's fine. What you say is correct. But generally nowadays we don't refer to as P210 or P190. We talk in terms of the transcript type. And while I wouldn't expect you to be answering, that'd be nice if you can answer it in terms of what is the relevance in the present era. Because what are the transcript types actually indicating? Yeah, you say, but they are all um, level not level, they're all level 2 evidences and level 3 evidences actually for the transcript type. But what is more relevant currently with the newer TKIs and the newer anti CML therapies that are available, targeted therapies? How do you have any idea as to how that is going to
Usually E13A2 it responds better than E14A2 is what I have read.
okay, that's fine. But it is important first for us to know about the transcript type from two perspectives. One, we have to look and understand from terms of the monitoring, because you're doing it with by the basically the BCR based, the PCR technique, and it'll be useful for us to know what is the transcript type that is there at baseline. So that's important for us to do. And now in the current era, is there anything, does it influence the treatment in any way or the choice of drugs in any way?
Mm. So it would help to differentiate between, not sure if between CML blast crisis and the ALL.
Not really, not really, not really. It doesn't have anything to do. You're right in some perspective. Yeah, B2A3 and B3A3 has got a little bit more. So generally, we like to refer to these transcript types as B2A3 or B3A3 or whatever it is. But important to identify B2A3, because currently in the era of newer drugs, especially drugs such as asciminib, which is a STAMP inhibitor, you say if you do have a B2A3 or a B3A3 which lacks the ABL1 exon, you can't use asciminib over
Okay,
there. It doesn't
not
work
used.
over there. So when you're using a drug, you should know that it has to work. So it does not work for B2A3, and though they are rare isoforms, but it doesn't work over there for those patients. So that is also now one of the newer uh, understanding as far as the transcripts are concerned. All right. So how would you go about? So you have categorized this as intermediate risk, and how would you want to go ahead with the treatment for this patient? Yeah.
Sir, this patient is a 19-year-old female. So, based on first is that our goal of treatment would be mainly to achieve a treatment-free.
What is the Utah score? What is the Utah? You also look at, even though the ELTS score is it's called the Utah, but what does the Utah score actually indicate?
Sir, if the probability of reaching a complete cytogenetic response at 18 months is
Correct.
what.
That's true. That's true. Okay. So that's fine. So what is her UTOS score over here? So we are definitely looking at an unusual situation because we don't see patients at the age of 19 with CML. They are rare, but you are having a patient with intermediate risk score, and you would like to optimize the treatment for this patient in the best possible way. So
Sir, I would like to think in terms of a treatment-free interval. And second is looking at she is falling into intermediate risk. And the fact that she is having no comorbidities. Because of all these things, I would still like to go ahead with a second generation TKI, mainly because I want to achieve a treatment-free remissions.
and what are the other aspects that you're keeping in mind to achieve an earlier responses in these patients? And that is based on what landmark studies?
So I would ask her while counseling the
Your
patient, I
decision
would,
is based what on what data? I would put it that way. Yeah, yeah.
sir, second generation TKIs such as dasatinib has been approved from the
Mhm,
Dasasion trial, sir. And nilotinib has been approved from the NS and trial,
mhm.
and bosutinib has been approved from the
So,
before trial, sir.
yeah.
All of
Okay,
them,
so go ahead. Yeah, go ahead.
uh,
So, that's fine. Yeah.
yes, sir. Sir, they are
So
all
that's what is governing
proven
your
to
decision
cause
to consider
fasting.
for the. So for this particular patient, you what would you consider as the first
Sir, I
line
would choose a
therapy?
second generation TKI. Dasatinib is what I would like to choose in her case. We can choose either of the TKIs, either of the second generation TKIs, but I
If
would
I
like
were
to
to see that, if I were to say that this patient, I would like to use high dose imatinib over here, like 600 milligrams over here, as against, am I wrong? And if so,
uh,
what is the data to support that?
Sir, there was that CML4 study which was done, sir. Which showed that increasing the doses of imatinib only increased the toxicity and without
Not,
improving the.
not so that was used at 800 milligrams. I specifically said 600 milligrams. Yeah. So the CML4 study, yes, for those patients who could tolerate the 600 milligrams, the results were equivalent to that of the second generation TKIs over there. Provided, of course, they did not have provided, of course, they tolerated the medicines. Yes, you are right in saying that it's difficult to tolerate and those medications, and the dosing that has to be used over there would be higher, but the results are equivalent to what you get. That's what the CML4 study showed, and that is equal to any of the data that is as far as the long-term outcomes of NS10D or for the factor the decision study. But anyway, that is just for a matter of discussion. So one should not lose sight of the fact that see, because one has to look at other problems that we and what are the other aspects that one need to consider as far as this lady, which will allow you to use a second generation
So first is the
TKI.
fact that she should be compliant. So I would like to explain to her about the importance of compliance to the treatment and adherence, that she should be on regular follow-ups at time points that we have asked her to. And I would
Yeah,
also.
that is true. But in this case, one has to keep in mind that she is 19-year-old and probably in probably hopefully in the next 4 5 years or so, she would be wanting to get into the family way. So if that is the case, we might have to start preparing her. Also with our understanding of how these things work, we need to probably look at trying to get an early response so that she has at least a reasonable period of time of deep responses, which will allow us to go in for a TFR, isn't it? Yeah.
Yes.
Yes. So
Yes.
that is something that is more compelling over here at this point of time. Yeah.
Yes.
Because before her treatment is completed, suppose we were to use imatinib, the chances that you are going to get, so as compared to nilotinib and dasatinib, what would you like to choose over here? You'd like to use dasatinib? You said one of the reasons is from the perspective of compliance, isn't it? Yeah.
Yes.
But the nilotinib has got little bit better data in terms of achieving uh, achieving long-term outcomes, though it is not much different, yeah, especially in terms of you're talking about a patient with intermediate risk disease. And if you look at the deeply, what did the Decision study say in terms of patients transforming to blast crisis as compared to the NSTND study?
The NSNT study, but in dasatinib, when we compared dasatinib with the imatinib, percentage of patients going into blast crisis in the dasatinib arm were around 3 to 4%, sir, compared to imatinib, which arm in which the percentage of patients going to blast crisis were around 8%.
Yeah, but what about nilotinib?
I have not read
Okay,
upon
so
the
there was a
NSNT study. I'm
less
not
number
sure.
actually as far as nilotinib was concerned. But anyway, those are all in terms of numbers. But for this patient, there is nothing like saying that they can go in for she can go in for
Treatment-free
dasatinib
interval.
or nilotinib, and for that matter, I would even say uh, imatinib. It's not so absolute, but in terms of the reasons that we have said in terms of trying to achieve the better early molecular responses. But because you must remember at the end of the day, none of them exhibited a better overall survival benefit in these
Yes.
patients. Yeah. So you want to start on dasatinib, and how would you monitor this patient subsequently? Yeah.
I would get a baseline evaluation of cardiac echo and baseline chest X-ray is what I would want to get, sir. And I would like to rule out pleural pericardial effusions. And
You don't
once I
actively
start
look
the
for
patient
that.
on
You'll ask
dasatinib,
those are all triggered when the patient has any symptoms associated with it, and something that you want to look for, like pleural effusion, because it is. Would you agree that it is idiosyncratic? Yeah.
sir, it could be induced by dasatinib alone.
Yeah, it can be induced, but even that is idiosyncratic, isn't it? It's not like as if you can even develop it much later. So it can
Yes.
even happen. It can even happen after several years of taking dasatinib. Yeah, but you're right. But so you have to keep in mind that this
Yes.
possibility is
And
there. Yeah. What are the other potential long-term
sir,
problems of
pulmonary
dasatinib?
hypertension.
Immediate-
Sir,
Yeah, that is pulmonary hypertension and immediate problems. Does it have any problems with the platelet dysfunction?
yes, sir, it can cause a dysfunctional
Yeah, so this also has to be kept in mind,
platelets,
especially in,
resulting in bleeding manifestation.
yeah, especially because sometimes this can be problematic. Sometimes in younger women, sometimes they can have excessive menstrual bleed and all those things because of the platelet dysfunction. Though it is rarely seen, but it has to be kept in mind. Yeah. So then, how do you monitor? You said you had to. So the first step is, of course, you want to look at molecular monitoring of these patients. Yeah. So what will be the time points of monitoring and how do you interpret that?
So I would initially I would call them every 2 weeks till the patient attains a complete hematological response, and after that I would like to call them at 3 months, 6 months, and 12 months, and so on, sir. And when I call them, I would like to look at clinically for splenomegaly. Along with that, I would also look for a CBC-DC and quantitative BCR-ABL, quantitative PCR for BCR-ABL, sir.
Okay. All right. What are the two aspects of decline of the BCR-ABL that you're interested in?
So one is the log reduction, sir, and the second is the velocity of decline of
Which is more
BCR-ABL.
sensitive? Yeah.
Sir, I'm not very sure, but I think velocity is it's
Well,
just
the
coming up.
data
The
has
data
been
is
it
just
has been
coming
there
up
for more
on
than
velocity.
6-7 years, maybe. But yes, you're right. But it's cumbersome to do the velocity of decline, isn't it? Yeah. So
Yes, sir.
because you have to look at the curves and the slopes of the curve to see what the velocity of decline. And ideally, according to the study, they were doing it every
1 month
every
interval.
month for seeing the velocity of decline. And that is again the importance of doing baseline transcript quantitative transcript levels for patients at baseline, because the slope of the decline is more important. Why so?
Sir, the steeper the slope, the better is their response to TKI. So faster will be their faster is their probability of achieving a deep molecular response, and we can probably put the patient on treatment-free interval faster.
That may not be an indicator, but of course, it is only to predict that the chances of them going in for a TFR is brighter. Yeah. So that is one thing. But yeah, so a patient having a 20% BCR-ABL at baseline and it becomes 10% is probably worse than a patient who's having 100% at baseline and coming down to 10%. So probably the second set of patients. So that is the importance of having the slope as a categorization for better outcomes. But it is difficult to do because you have to have multiple at various time points to do so. We still resort to the early molecular response, which is at 3 months to decide. Yeah. Okay. So this patient has what will be your advice to this patient subsequently once she has achieved an early molecular response?
So again, I would like to stick to compliance, the importance of compliance, and I would explain the toxicities, but that the patient should be coming back again for qPCR levels at 6 monthly interval, like at 6 months and at 12 months.
Okay, and then
Uh,
how does that help you make some decisions for the patient?
Sir, I would like to explain that if we are able to achieve a deep molecular response, and if we maintain that for more than 2 years, then we would be able to, and that is provided that she takes a treatment of more than 3 to 4 years. And if subsequently, if
What's
she
the
goes
ideal
into deep molecular
situation? What is the
response
ideal
for 2 years,
situation where we'd like to, where we would, for a newly diagnosed, so she's 19, she will, at what point of time would you want to, if the patient
sir,
at
at
least
least uh, minimum of 4 years of treatment, sir. And she has to be in
3 years, at least three, though the Eurosky study them
Yes.
allowed for at least 2 years, at 2 years of deep molecular remission. But the data would clearly say that patients who have achieved a response which is sustained for about 5 years have a better chance of sustaining a TFR than those patients who are less than that. So if the patient can go to have a 5-year period of deep molecular remission and then stop, the chances are better. But you can consider it after 2 years also based on the Eurosky data. Yeah. So, but longer, it is very clear that longer and sustain the responses, the better. So I think I'm running out of time. Is that Bobbin? Yeah. And
Sir,
So we have a
yeah,
few more minutes, sir.
sir, I
okay.
think we can continue for 10 more minutes. And
No, no. So I would like my colleagues to also ask some questions. Yeah. Yeah.
Yes. So I think one major question we had asked about treatment-free period. What other advice when you are considering for this patient? What would be the other advice that you are doing? Let us say this patient has now become 23 years old. She is in deep molecular response for the last 3 years. So you're considering for a TFR because she wants to start planning a family. What other are the instructions or the requirement to keep her off treatment free?
I'm not sure, sir. If she has to be in the chronic phase all the time. She should never have progressed into accelerated or blast crisis, and she should have attained all the optimal
You have
milestones.
attained all that. What else further? Now you are going to, you decided you're going to stop your second generation TK. What else would be your advice to this particular patient in your OPD? This is the first time you are going to consider
Yes,
TFR.
yes,
So
sir.
what is
Sir,
the
I would,
advice to the patient? Just simulate that scenario.
sir, I would ask her to repeat the Q PCR for PCR ABL every monthly for the next 6 months. And I would tell that if there is a loss of a major molecular response, then I would will be restarting the TKIs. If she still continues to be in the deep molecular response and the only the MMR is lost, only then we'll be considering starting the TKIs.
Fine. That's what I want. Your intensity of monitoring initially should be monthly, and then you can change to the
To
after this.
2 months. Yes.
And in this patient, let us say she's in deep molecular response, treatment-free period for 1.5 months. She decides to get married and start. She starts. I mean, she has a pregnancy.
Yes.
And in your first trimester, as the patient approaches you, she has probably a small transcript popping up. You have a loss of deep molecular response. What would you do? Patient is pregnant, maybe around 12 weeks. I mean, at the end of first trimester.
First TKIs are totally contraindicated, sir. In the second and third trimesters, we would still consider the second generation TKIs. But if since given the fact that she's in the first trimester and if she is losing her molecular response, then I would like to treat her with interferon, consider interferons. And in case if her counts are rising significantly, then I would like to go for a leukapheresis. If thrombocytosis is what we're concerned, then we can put her on aspirin.
Yeah, I mean, even before, as you are monitoring these patients very frequently, we can even consider probably even hydroxyurea before you go
Hydria.
for hydroxyurea before you go
Yes.
for leukapheresis, because
Interferons.
you're going to be closely monitoring this patient. But is there any criteria cutoff to start interferons?
Sir, I'm unable to recall. I've read, but I'm unable to recall that at this point.
So, I mean, we don't need to jump just the loss. I mean, we are obviously going to be wary for it. Probably also we need to check the next serial values at shorter interval. And we find a rising trend, loss of complete. I mean, once you start having loss, then we would start interferon. Probably, transcript. Correct me if I'm wrong, sir. Transcript number copies are going
Yeah.
up. Probably 2 serial
Yeah.
values.
So
I don't think if just one 0 point value of 0.01, we may not immediately act. We keep a close follow.
always you look for log increase for these things to determine whether you want to start treatments, because sometimes even for TFRs, when you're looking at, if you look at the Rubinstein's data, you can have a low level of this thing which will continue, and that also is adequate enough to sustaining the TFR strategy. Yeah, so I think well done. I think you have read quite well. Are there any more questions, Nikhil? I mean, I don't know. I'm not.
Since they are a transplant center, I would have a bias to what would be the, I mean, in addition to blast crisis, in a patient in chronic phase, what would be, this is a little bit of a trick question only, but in a chronic phase patient, when would you consider bone marrow transplant?
So definitely for blast crisis, if we can get the disease into remission, because they are never going to be durable responses and they are sensitive to transplant, we would definitely offer a transplant. And currently in the era of patients having T315I mutation, even though we have drugs to tackle this like asciminib, but they have to be sustained therapy and they can never come out of it, and they are never going to be patients who are going in for a TFR. So, and if the patient is young, then we would certainly consider offering transplant earlier than later, primarily because we know that with CML, if you look at the Gradfold scoring system, the longer that you have CML, worse is going to be the outcomes in terms of TRMs. And so one would like to take that decision earlier in these patients than later for a transplant. So that is the way I would look at it. So people would say, why go for a transplant? But at the end of the day, even today, even though transplant has gone out of vogue for treating CML patients, it's still one of the best indications for doing a transplant because the outcomes and the graft versus leukemia effect is most profound, and the immune-based mediated responses are most profound in CML. But it's all about timing of the transplant that you need to take decisions, and which it's very clear that if you do delayed transplants in CML, the outcomes are never
Dr.
going to be good.
Pavitra, the message, as sir said, keep in mind, even in CML, CP, there's a role for transplant, multi-drug resistant. One particular scenario probably is people are not able to,
Tolerate two or
continue.
more TKIs.
Yeah, 2 or more TK. So also all the other questions about TK resistance, etc., are to be expected. And a short note on transplant, keeping in mind that you have one of the best graft versus leukemia effect in CML. Another rare scenario, possibly just off topic, is that's very rarely where some patients on TKA can go for bone marrow aplasia and failure syndrome. Very rare. And that would be one other indication. Usually, if they don't have recovery after 2 to 3 months, you have to consider transplant as a rescue or a salvage rather than a primary disease treatment.
Bone marrow necrosis is one of the very rare side effects of TKI therapy. Yeah.
Hari sir and Nikhil sir, shall we take a few questions that were asked in the chat box?
Sure, please.
For the next 2 minutes, I think. One question was asked about dasatinib 50 mg versus 100 mg.
So if you ask the purists, still 100 milligrams is better. So I was talking to the people who had brought in dasatinib, Andreas Hockhaus, and this thing. So if you look at the pharmacokinetics and of dasatinib, it has got a very short. It's got a very short half-life. Here, and you need to, and the levels actually count over there in terms of inducing a cell kill or inhibition of the BCR-ABL, or the BCR-ABL. But so if you look at the pharmacokinetics, it doesn't make sense for us to actually use 50 milligram, but the data is there. But we also know that the data is most strong from one single center, which is MD Anderson. If you look at people in Europe, they would use definitely 100 milligrams of dasatinib, but the data is there for 50 milligrams, but it has not been reproduced as well as what has been produced by MD Anderson, which has shown equivalent results.
Sir, if I'm not mistaken, this particular question, I think it's not even that old and study where they looked at the levels also. I think some level of 3 they kept as the efficiency, and they did some randomization. Patients would not achieve that level either. Or achieve that level, they did drop the dose or they continued the same dose. They found efficacy maintained once this level was there, even if they reduced it to 50. But I think toxicity was much higher for the 100. That's if I remember correctly. I think it's a same thing you're saying, the MD Anderson study. There's for dasatinib, I think. But I would play safe. I would. I'm looking to. We are all in the era where we are looking to deeper responses. So probably we start off with 100 and stick to that.
So you can always look at the data for de-escalation strategy. There is a good data on that where you have, once you achieve the responses, you can come down on the dosing in the process of actually going in for a TFR, for a de-escalation strategy. There's data for that. Yeah.
And sir, then can we offer TFR for patients on asciminib? Is the another question that is coming.
Yeah, right now, I think from my simplistic understanding, the data from the first line asciminib trial, where you had the investigator choice and then asciminib, a lot of the endpoints were more for achieving, TFR. 48-week, molecular response, etc., and all were much higher, obviously, in asciminib, as we have seen also traditionally. But that being said, first line asciminib may not be in our current practice a go-to choice. I'm still comfortable using second generation TKI, or probably I'll wait for the longer follow-up of the
So there
trial.
definitely there is it is sort of has got an edge over the other TKs because the
Allosteric stand.
the it's a different pocket at which myristoyl pocket which it acts on. So there is a higher incidence as compared to the if you were to cross compare the Decision study, etc. There is a better outcome in these patients in terms of outcome means in achieving the endpoints, it is a little bit superior. So that is where it has been. But the thing that actually stands out for asciminib is its safety profile and its low on toxicity, which has actually gained credibility over a period of time for using asciminib. But we haven't used it because of the sheer cost that is associated with it.
And I think, sir, one more thing is there have been multiple questions, so we'll just take that. And that at baseline, what tests are to be done? I think you had asked Pavitra about that, but then people have been asking that whether it's BCR-ABL fish or BCR-ABL qualitative PCR.
Currently, only we are doing fish because, as was rightly said, cryptic translocations can be picked up only by fish. And if we have a strong suspicion that that it is CML, then we will certainly do a fish also to prove or disprove that this is CML. But if you do have the BCR-ABL transcripts, other than for the conventional cytogenetics, there is no added value for doing fish over there.
Fine, sir. I think we have nicely discussed, and shall we then close the session, sir?
Certainly, yeah.
Yeah. So thank you, Dr. Pavitra. I think it was excellent. Like, you have tried to answer everything and well prepared. And thank you, Hari sir and Nikhil sir, for your expertise and giving us time to discuss a very important topic. And it can go in any direction during the exams, actually. So well handled by Dr. Pavitra. So thank you so much, sir. Thank you so much for your time. And I think we will close the session here. Good night.
Thank you, Hari sir. I was coughing half the time, and because you were in charge, I luckily didn't have to ask any questions. And well done, Dr. Pavitra. Please keep it up and focus on your basics, including your CBC peripheral smear and all that. You have done the basics well. Thank you.
Thank you. Thank you. Well done.
Thank you.
Thank you. Yeah.